Hello, this is Deborah Waroff with MECFS Alert. We're in San Francisco today at the International Association of Chronic Fatigue Syndrome and Myalgic Encephalomyelitis. And I have with me Dr. Jose Montoya, who is the head of the Stanford MECFS initiative. I'd like to ask Dr. Montoya, how is it that you were first attracted to MECFS? I know you were an infectious disease doctor and still are. How did we grab you?
February 2004.
Aha.
I had a patient who was sent to me because it was thought that she had very high active levels of three herpes viruses, CMV, EBV, and human herpes virus 6. So that was really the first face-to-face encounter with this illness. And of course I approached the patient with my background, and indeed I saw that there were good indicators that these three viruses were very active. But what struck me the most was seeing how long this patient had been sick. And you know, I'm sure that in the mind of the physician who referred the patient to me was, this is a viral infection, a few weeks, and can he do something? But I paid more attention to the other part that had not been emphasized in this consult. And after concluding that it was worthwhile trying an antiviral, I did the valganciclovir treatment. And a few weeks later, when the patient called me back to say how she was doing, there was this striking comment from the patient: my fatigue is better, my cognitive function is better. And rather than put it at the side, I decided to pay attention to it. So it was seeing this patient suffering for so long what attracted me to see maybe infection has a role here in this illness, three herpes viruses. And I obviously agree with the referring physician that that was the case. But what struck me the most was when she described the pain and the suffering that she had experienced with the illness, that she had been fatigued and cognitive difficulties for 13 years. And I pay attention a lot to that part. And I did my job. I gave her the antivirals, valganciclovir, that in our field is well recognized, that has good anti-herpes activity. But what struck me the most was not seeing those viruses almost fading, not disappearing, but fading, and she getting better from her lymph nodes and her low-grade temperature and sore throat. But what struck me the most was that she called me weeks later and said, my fatigue is much better, my cognitive function is better. And I decided to pay attention to that. I decided that, that as a physician, I have to believe my patients. If they tell me that they have symptoms and that they are sick, it's because they are indeed sick. And one patient led to the other, and then it opened completely a new world for me that I had not had the privilege to be in or to work in.
And you mentioned earlier to me that you've had an experience, as Ken Friedman has, of the academic world not being entirely hospitable, not entirely respecting your work at CFS, although they did give you tenure based on your other work. Now, why do you think that is? Why can't they wait a few years for a result? Why can't the academic world tolerate something that isn't immediately producing?
Well, I think the academic environment is not immune to the prevailing view. It's a sad view that has permeated every corner of society, that ME, CFS is a psychological, and by saying psychological, I'm not by any way derogating of psychological illnesses, but that ME is a psychosomatic disorder. Unfortunately, that has also permeated the academic environment. So I think academic centers are not immune to that misconception, to that, and physicians, professors, like in my case, who work in that illness, are viewed with skepticism as well. And people are just holding their breath to see if we produce something that is valuable or not. we have been fortunate at Stanford to be able to gather an outstanding team of collaborators and investigators. We have top immunologists like Mark Davis, geneticists like Ron Davis, Michael Zinner in neuroradiology, cardiology, Francois Haddad and Mary Skiri. So we have this fantastic team of scientific minds, and the core ME/CFS team at Stanford is super, couldn't be better. Jane Norris, Ian Valencia, Diana Dobbs, Amy, Amity, Stephen, they all have their heart and their minds in the right place. And with one major goal is how can we contribute to make ME/CFS preventable, treatable, and our ultimate goal is to make it curable.
You said earlier that you couldn't stand to watch people suffering and not take it in. There are so many physicians and researchers who can stand to see people suffering. Sometimes I think who rather enjoy, in some cases, seeing them suffering. Do you have any sense of what the difference is, what separates those who can't stand to see it and those who are indifferent at best?
I cannot speak for that. I know that there are other physicians and researchers and clinician scientists that share that passion of mine of if you could see in your mind all the human suffering in the world, that what drives many of them and me is to shrink that overall human suffering. And some beautiful work and people do it through decreasing poverty, and and then we have the privilege to try to do it through medicine and through research.
What would you underline as your major project for the coming year, in meaning the initiative?
Now you excite me. So we wanna go for the central pathogenesis of ME/CFS. What really is at the bottom of the illness? It's like going after the carotid artery, like this main artery we have in our neck, or the jugular vein, going to the central aspect of the disease. That if we can put the building block or the few building blocks or nail that what primarily is wrong with the patients, then we will have one big smile of satisfaction then.
Yes. I'll just mention, I always have in my mind this image, and of course I'm safe from being wrong because I know absolutely nothing about this subject, but I always think there's the immune system and the other systems, the cognitive, and some little thing comes along, a herpes or a mold for some people, and it just goes like this, and it's never the same again. Do you think that could be reasonable?
I think that I like your analogy. I will just perhaps add that as this system, this equilibrium that our immune system has ingrained in its network, there is a wisdom there of that system being in equilibrium that allow us to smile and to be happy and to do whatever we are passionate about in life. And when it gets hit, like you said, and there are some people probably that are more predisposed to take those hits even worse, then the equilibrium that makes us healthy is shifted to another. But I don't want to underestimate the fact that this new equilibrium of the immune system that make the patient sick and not think well, and pain and fatigue, has an equilibrium in its own, and it has another kind of wisdom that unfortunately that new equilibrium with a different wisdom makes the patient sick. And so that's probably what makes it really hard to get it back to the original state where patients were enjoying the normal life. So I think that once we nail it, once we know exactly what took the patient to go from the equilibrium of health to the equilibrium of illness, then we have to be very smart on how to take that back, but there will be resistance. The immune system will try not to change, because if you look at the long-term history of the patients with the illness, they are suffering great deal, and they are suffering like the cancer patient, like the stroke patient, but they are not dying like the cancer patient, like the stroke patient, at least short term. So something is allowing that system to persist and to be alive, that is making the patient sick, but there is an internal wisdom that is different than the one of the healthy individual. So what we have envisioned at Stanford is we want to exactly know how is it disturbed, like you said, that makes it crumble and fall apart, but we have to be very smart in our attempts to get it back to normality, that we can overcome not only the fact that it's disturbed, but its resilience to change and get back to normality.
I think that's a very elegant and poetic description of what faces researchers and patients in this area. And I thank you very much for stopping by and sharing it with us.
It's a pleasure to talk to you, Deborah.
It's lovely to meet you. Thank you.
Thank you.